audience knows that bleeding is our main enemy during endoscopic surgery. And when it bleeds, we have, of course, decreased precision, we have increased incidence of complications, residual disease, we have increased perioperative trauma and operative time, blood loss, and hospital stay. And all these result in increased cost of treatment. There are some factors contributing to bleeding, and some factors may be controlled by doctors prior to surgery. Some may not be controlled. Patients' factors like obesity and smoking both are thought to increase bleeding during surgery. Density of vascular network in mucosa depends on the state of mucosa. In entropic rhinitis, we have usually very scarce network, so the bleeding during surgeries is minimal. But in hypertrophic rhinitis, we have very dense network of vessels, and bleeding is profuse. And of course, hemodynamic state of cardiovascular system also matters during the operation. How can we prevent intraoperative bleeding? Some authors claim that local anesthesia decreases bleeding, but it's not proved, really proved in the literature. Topical vasoconstrictors like adrenaline, for example, administered prior to surgery decreases vascular bleeding. Reverse Trendelenburg position, so putting the patient in this position causes retention of blood in lower parts of the body and decreases mainly venous bleeding. But the most important is heart rate and blood pressure. But if we decrease heart rate and blood pressure too aggressively, it may result in decreased cerebral perfusion and neurological complications. What we tried to do was decrease heart rate and blood pressure during fast and scalp-based surgery to assess low bleeding during operations. The surgical field was assessed from a Bedford scale. We aimed at first 3 grades of this scale. This grade 1, as you can see, there is very minor bleeding, very small bleeding, and suction is not necessary. Just to compare, grade 3, also pretty small bleeding, but we have frequently used suction to remove that from the operating field. And grade 5 is so profuse that we have to use suction all the time. So we aimed at this situation. When we decrease heart rate and blood pressure and achieve these final results, so bloodless surgical field, we measured with transcranial color Doppler sonography blood flow in the middle cerebral artery, and results were quite surprising to us, because this is the initial stage of the operation. Heart rate is 78 per minute. MAP is around, mean arterial pressure is around 80. So we have pretty profuse bleeding, and in sonography we have very nice wave of blood flow. But when we achieve this stage of the operation, so bloodless surgical field, at a heart rate of 62 beats per minute and MAP around 65, we have very severely or profusely decreased of blood flow velocity in the middle cerebral artery, and it dropped in this particular case even below normal reference range. The preliminary findings we published 2 years ago in Clinical Otolaryngology, and at that time we made three conclusions. That bloodless surgical field denote also reduction of blood flow in the middle cerebral artery. This is because both these arteries, I mean ethmoidal arteries coming from ophthalmic arteries, of course, and middle cranial artery arise from a main trunk of internal carotid artery. Blood flow velocity in some patients may drop below normal reference range in healthy subjects. These are lower limits depending on age-depending limits of blood flow velocity. In some patients, it really dropped far below lower range. And this drop, what is most crucial, most important, is that this drop may occur even though blood pressure and heart rate are maintained in so-called safe limits. So we never go lower than 60 beats per minute for the heart rate and 60 millimeter for the blood pressure. The results in detail prior to the anesthesia, as you can see, blood flow velocity in the middle cerebral artery remain within the normal range of a-specific reference values. When we get a bloodless surgical field, the reduction was by 45% on average. In 40% of cases, the mean blood flow velocity dropped below normal reference range. It seemed a bit dangerous to us, so we went a step further. We assessed serum concentration of neuron-specific MLAs. It's a marker suggested for neural tissue damage. We assessed it 24 hours post-operatively and 48 hours post-operatively. And in five patients, we found that the level of this enzyme was elevated. Of course, this elevation or these peaks of concentration of this enzyme never reached the level that is seen or found in patients after cardiac arrest or after cardiac surgery. But anyway, it reached the level above 30, which is thought to be very specific for neural tissue damage. In our group of patients, no neurological complications were detected. To conclude, whenever we operate and we have bloodless surgical field, we should be aware of the fact that this may also denote drop of blood flow in the middle cerebral artery. And this drop of blood flow in the middle cerebral artery may be associated with a rise of serum concentration of NSE in operated patients. And we think that further investigation determine safety limits of these methods are warranted to determine the safety limits of decreasing chemodynamic parameters. Here I mean to use other neuromarkers and perform some neuropsychological examinations in long-term observation to determine whether probably these patients may suffer from some cognitive function impairment or some anxiety or depression. Thank you for your attention.
Nice presentation, Andres. Any questions or comments?
Thank you, sir. It's very, very nice of you to give a wonderful presentation. You have been doing endoscopy, right? FES. And to have bleeding in FES is like killing the doctor rather than the patient. It's so dangerous. I did not understand the fact that you stop the bleeding. The bleeding is there. Now the patient is bleeding and you are doing an endoscopy and the patient is having a severe bleeding. Now what are you going to do? Are you going to locate the middle meningeal artery? Are you going to do what? Because he's going to bleed now. Now you are the only person who's going to deal with this bleeding.
Yeah. It depends on, if I understood you well, it depends on the type of bleeding. If we have vascular bleeding, I mean from.
It is always vascular bleeding.
Yeah, I mean.
It is always vascular bleeding because there's the saphenopalatine, long branch of the saphenopalatine artery is the one which is very worse, and that once bleeds, it's very, very difficult to control it.
Yeah, yeah. But sometimes it's single point bleeding. We can cauterize the single point bleeding, right? If we have capillary bleeding, for example, some vasoconstrictors may work. If you have venous bleeding.
Sorry, sir.
Yeah.
Vasoconstriction doesn't do anything to that patient.
Yeah. So we can decrease
I'm
blood
telling you,
pressure.
I've been doing these tests for quite some time. Vasoconstrictor doesn't do. We always use vasoconstrictor. We use for small vessels. Yes, you are very right. We use for vasoconstrictor for small vessels, and these vessels are controlled by a vasoconstrictor. You can have a swab soaked with vasoconstrictor and put it there, and then the bleeding stops. But what if there's too much bleeding?
Yeah, the only solution is to decrease blood pressure and heart rate. It's really, in such situation, we can at least diminish bleeding a bit to be more precise during the
Let me tell
operation.
you my experience.
Yes, sure,
You
of
may
course.
be very right. You see, the fact of the matter is there has been bleeding. There has been bleeding with me also in one or two occasions where I was really nervous and I couldn't control the bleeding. The only thing that I did was pack it. Pack the nose and leave it, please.
Yeah.
Why? Because it is an arterial bleeding, as you have said, and arteries have got a tendency to shrink. You know, they have got tunica intima, tunica media, and these fibrous tissue constricts. Well, in cases of vein, it doesn't have a tunica media, right? Is it so? So that constricts. If you press it and pack it for quite some time, the bleeding is controlled. That is what I have done. Yes, reverse tender position, ask the patient to reduce the blood pressure. Well, you can do these things. These are secondary things.
Sure. Every surgeon has its own tricks to control bleeding.
Thank you.
Okay?
Thank you for sharing your experience. Dr. Time, it was very good. And as we all learn with these type of questions and with comments. Any other comment or question? Thank you.
Thank you for a nice presentation. As you have mentioned, bleeding during functional endoscopic sinus surgery is a problem. But I think every surgeon has got individual style to deal with. But the most universally and most commonly practiced measures that we do in surgery for functional endoscopic sinus surgeries, some of the people keeps the nose packed for a few minutes, say 20 minutes, 30 minutes before surgery with some vasoconstrictor acid. This is one method style. Someone deals with in the surgery when they finds after this procedure there is bleeding during the procedure. Someone keeps the area packed with a vasoconstrictor solution, soap gauze or pack. They waits for some time. Then most of the bleeding stops or comes to a reasonable amount so that he can continue to go through surgery. And finally, there is a relationship. There is an understanding of surgeon and the anesthetists. Finally, the anesthetist comes into the play the role. He reduces the blood pressure and he tries to maintain an hypotensive anesthesia throughout the surgery, and there it reduces the mean arterial pressure. And probably these all the things deals bleeding during the surgery. So it is all the individual surgeons and his team's practice and his institutes or department practice how to deal with bleeding during surgery. Thank you.
Thank you for your comment. Thank you.
Thank you for the comprehensive presentation. Actually, I want to comment of my colleague what he just said. I believe that Dr. Adias was stating about this exact surgical field during surgery, about the mucosal bleeding, which is tremendously can be covered, as he said, by decreasing the heart rate and the blood pressure. And in the matter of you have bleeding, depends what you hit. If you hit the sphenopalatine, you can either by backing or you can directly ligate the sphenopalatine or clip it. If you work on this frontal sinus and you hit the anterior mode, you can just not just back it and you see the eye is rising up and you have a retrobubble hematoma. That way you have to act rightly. But I just have a question for you. Do you use injections before you start, as local injections, turbinates or something, or no?
Very rarely. When I operate frontal sinus, I do some injections, but normally no.
Thank you.
I use local anesthetics injections. Before operating, I use. And if you are doing it under local anesthesia, then you have to localize the area of the uncinate process and all that area where you have to go to the ithmide and all that. You have to anesthetize with the insulin syringe or whatever, small syringe. Otherwise, if you are doing it under general anesthesia, then there is no need to anesthetize, to give a local anesthesia. Yeah.
Thanks. Any other questions?